give full marks because this is severe mitral regurgitation, and you can see the mitral valve to some extent little bit, and this is opaque. We will go to the grading later on. So this case was iatrogenic MR because the catheter was too much near the mitral valve. It is over here. So and that is one of the reasons is too much near the wall also, to the posterior wall and posterior surface of the left ventricle, and that's why we are having so many of ectopics. So now tell me, where will be the right ventricle? It will be anteriorly or posteriorly? This is again which view? Quickly, we have to keep learning. Science is it is a continuous learning process. Which view? Which view? There is no catheter over here at this point of time. So spine is on the right side. So this is right oblique anterior oblique view, and there is no diaphragm seen. So there is no angulation. So this is likely plain RO view. And as I said, left ventricle is seen over here, and this is left atrium. Now, right ventricle is exactly anterior to it, along with the right atrium. So this is the view where once somebody is injecting, you have to base your findings on the various characteristics of the cavity and which vessel is ultimately getting filled, and from where the catheter is coming. Otherwise, view-wise, they are overlapping on each other in the right anterior oblique view. And here is the normal contractility. You see over here the left ventricle. You have to see both things: inward motion of the wall as well as thickening. Why this is important? Because what happens is, if let us say there is hypokinesia of over a small myocardial segment, then because of the compensatory hyperkinesis of the adjacent segments, it may appear to be moving very well. So you may miss it if you base it only on the motion of that particular segment, LV segment. So both things have to be there. Both inward motion as well as thickening have to be observed. So this is a kinase and all that. We'll see it later on. So based on RO view and LO view, you can to some extent tell which artery is likely involved if it is a case of myocardial infarction. For example, over here, this is important because this was asked in our exam. I don't know if this will be asked, but at least you have to know it, even if it is asked or not. Anterobasal, anterolateral, apical, and these are all supplied by left anterior descending, and diaphragmatic supplied by posterior descending artery, and this is PLV branch posterobasal, or for that matter right coronary artery. It is important to note over here, Dr. Safal and I have seen, innumerable patients, thousands and thousands of patients with anterior infarction, and many of them have ultimately, got salvaged either by thrombolysis or primary PSA. But what I've seen is that this area is typically in most cases, unless it is thrombolysis or primary PSA is done within an hour or so, this is typically, gone. So this small area is gone, and after that more damage occurs depending on lesion is proximal or distal LAD and when revascularization is done. So this is a case, chest pain 3 days ago, presently no chest pain. This I should have played later on. So tell me what it is. Which area is involved? Which segments are involved? See it again and then I'll come back to it later. So this is typically LAD involvement is there. As you can see over here, this all is LAD area and this all is gone. And this is the angiogram. Chest pain 2 days ago. Presently, patient is having mild chest pain. Let me show this, the other one later on. Students, you have to respond. You cannot just keep, even if you give wrong answer, it doesn't matter. Type your answers, because I am not seeing much response. Let me see how many participants are there. We have 62 participants and none of them is responding. I mean, this is unacceptable, honestly.
Apical aneurysm, LV, apical ballooning, they have typed in their responses.
Okay. Why I'm not able to see the response?
Yes, some boy has now typed basal hypokinesia.
Yeah.
Apical ballooning, apical aneurysm.
So this is a very, okay, somebody is typing actually. I'm not seeing it. Okay, yes. So there is no aneurysm. See, it is okay to give wrong answers. It's okay to give wrong answer. It's okay. No problem with that. See, the apex is, actually perhaps many a times what happens is, if injector is not working, so sometimes we give hand injection sort of, not a great practice, but nevertheless, the LED territory is moving very well. So it is only this territory is moving less. And this was a co-dominant right coronary artery, LCX and RCA. And you can see this is 100% blocked over here. So unless you see lots of them, you will not be able to identify. Now tell me, okay, LCX, okay, great. Now coming over to left ventricular angiogram. What happens is, if you have a sheet of paper lying in front of you, then it is like a RO view. That is, RV is above that sheet of paper and LV is behind the sheet of paper. However, if you hold the sheet of paper like this, then on the right side on your screen will be the left ventricle, that is laterally or just ascend to the spine, and just ascend to the sternum, you will have the left ventricle, as you see over here. So this is the interventricular septum, and we are injecting into the normal left ventricle, and this is the cataract course, and this is a retrogradely we have punctured it, looking like this. And in this view, we are able to see, ideally, conventional teaching was that if you want to tell about the renal wall motion abnormality in a given subject, so you must take the view in, must take LV angiogram in both the views, LAO as well as RAO, because both will give you different information. Similar to, you cannot conclude a echocardiogram examination just by doing you a pastel log axis examination. You have to see 4 chamber, 2 chamber, because in 4 chamber you will see other walls, septum and so on, and in 2 chamber you will see anterior and inferior. There you will see septum and lateral wall. So similarly over here you will see lateral wall supplied predominantly left circumflex, and here you will see basal septum and apical septum. Basal supplied by the septal branches of PDA, and this supplied by septal branches of LAD. Now the question arises, this is same thing shown a little bit with overlap of the color, and this is the right anterior oblique 30 degree. Here another question is asked is, which aortic cusp you see? You see in the RO view, you see the right coronary cusp and non-coronary cusp. And as I said, both the ventricles are overlying each other. Our interventricular septum normally lies in the heart obliquely. So this is the AP view, and it is about 50 degrees to the left side like this. When you do our right anterior oblique, then the septum becomes perpendicular to the beam. That is, it is like this. In the LAO view, it will be like this. And in the LAO view, you will see left and right coronary cusp clearly, and the non-coronary cusp will be, protruding in between both of them. So this is important to note. Now tell me what it is. Little bit tricky. See everything. See the aorta, see the left ventricle, see everything. Apical SCM. Why do you say this is apical SCM? See, somebody has nicely said aortic regurgitation. It is not. For aortic regurgitation, this catheter is not the right one to tell you about that. Reason being, once the catheter is there, then the leaflets cannot coapt adequately. So there will be inherent aortic regurgitation. Very good. Somebody has, at least to some extent, rightly said, somebody has said RSOB closure. It is not, it's not like that, but nevertheless, very, very near full marks. It is actually unruptured calcified aneurysm. And here your knowledge comes in handy. See over here and see at the back. Right cusp, non-conic cusp. So this is aneurysm of the unruptured aneurysm of the non-conic cusp. And it is calcified. That is why it is so well seen over here. Left ventricle is normal, and as I said, AR we cannot comment because our catheter is, impinging the closure of the aortic valve. There is no mitral leak. So this is calcified. Dr. Safal, you want to say something?
So very good mistake that somebody has made. Everybody will gain from it. Just the way you were shown iatrogenic MR, with a catheter or a wire inside, you do not comment on aortic regurgitation. And many of you will be going ahead either doing or assisting in TAVIs. So please, when that heavy safari wire is in and you see AR, so don't get nervous. A lot of that AR, that's now become one of the commonest things where we are looking for AR on angio. When your wire is across, do not rely on the central AR that you are getting on your angiogram. And obviously for AR, you will be giving your shot in the aortic root and preferably a little away from the valve. So good mistake that you made. We can all get a learning point from that. Whoever has made that mistake.
Okay, so it's okay to make mistakes. It is part of the process. I'm happy that
good in the learning phase that they make.
Yeah. It's good. It's okay. Like you will see AR in practically all the LV angiograms. Even over here you can see. It's quite marked actually. So why somebody has said the Takotsubo cardiomyopathy, but you have to give me reason. There has to be explanation for everything. I call it that this is a likely NTA wall infarction. I have few slides on Takotsubo. Okay, apical ballooning. And what is the clinching? If somebody asks you why it is Takotsubo, you have to give the correct answer. Because I am calling it as it is a NTA wall infarction. Patient in fact presented with chest pain. Patient in fact did have changes in the ST elevation in the NTA leads. So this is NTA wall MI. So this is what this thing. Okay, angio is normal. Very good. Normal. Okay. And more importantly, as you will see, thickness. See, initial phase thickness will be preserved. Once the infarction has occurred, thickness initially till a scar is formed, thickness will be preserved. More important and more correct answer will be for examiner's satisfaction. Here you can write anything, I don't mind. Basal hyperkinesia. Okay. So there is involvement of more than one territory actually. So you have involvement of the LAD as well as the RCA territory involvement. So involvement of two territories, it can occur. I'm not saying it, but it will be very rare. And these very nicely said, somebody said basal hyperkinesia. So there will be compensatory hyperkinesia. So this is a few words about Takotsubo cardiomyopathy. So LV function recovers in 1 to 4 weeks. And there is a thing called why it occurs. Tell me why it occurs. It is already written over here, unfortunately. Emotional or physical stress. There is a similar syndrome called as happy heart syndrome, which has almost similar presentation. So, can anyone tell what it is based on? Why it is called as Takasubo? Why from where the word has been, taken? Okay, Japanese, from a toy, not a toy. It is a basically octopus trap. Okay, this is octopus trap where where it is used to catch the octopus. It is like this, and here it is like this. Why it is? There are various names. Somebody said, they are basically descriptive names: apical Benoni syndrome, broken heart syndrome, and stress-induced cardiomyopathy. And what is the prognosis? We saw that. I want people to answer what is the prognosis and what is the presentation. How they will present actually. Let us say somebody, it's a good prognosis. I mean, how good? Do all of them recover? Do all of them recover? Yes or no? Will all of them recover? I mean, somebody has unfortunately a fatal event. Present as arrhythmia, embolism, failure, acute heart failure. Very good. But most important, you have not told me. See, most important is acute coronary syndrome presentation. Of course, very rightly said. 50% recover, a little bit more recover actually. May account for up to 2% patients with, suspected chest ACS, and importantly, they will have ECG changes similar to acute myocardial infarction. So somebody rightly said the key lies in proving it by doing an angiogram, and most importantly, they are antecedent events and much more common in women. 90% are women, and contrary to popular belief, much more common in post-menopausal women. As per the series, of course, you see lot of young patients, but the cluster of patients will be typically in the middle age or so. Lot of, as I said. So diagnostic criteria, as I said, transient, how will we say once it recovers? Initially, we cannot say it. The RWMA along with beyond the distribution of a single epicardial vessel. This is the key. You have to say it. You have to say that it involves more than one. That only then your answer will be complete and you will get good marks. Absence of obstructive disease, new ST elevation, depression, T inversions, everything can occur. Important thing is, because other conditions like myocarditis and pheochromocytoma, catecholamine storm, even head trauma, these things have been noted very well in patients who have absolutely normal coronaries, normal heart to begin with, and intracranial bleeding and those kind of things. Because you may be called, that patient has, for referral, that patient has suffered a massive bleeding, patient is unconscious, EC is going haywire, you have ST elevation and all that. So take the transfer to your side. We'll manage this thing later on. Put it at the heart. Nothing doing. It is, for most part, it is because of the raised ICT. Pathogenesis, no one knows. Catecholamine excess is supposed to be the key and the most plausible hypothesis. Coronary artery spasm, microvascular spasm, or maybe some sort of unidentified myocarditis has been there. And tell me, what is the role of enzymes? So these presentations we have already discussed, and as somebody said, they can present with ACS as well as, because of the lot of myocardium is involved, present with shock, cardiogenic shock, LVF and so on. And important, one of the other important presentations is tachyarrhythmias or bradyarrhythmias, which one has to, occur. Can a thrombus form in these patients? Yes, it can form. Evaluation, I'm not going to detail. We have no flow limiting this thing. Management is predominantly supportive. Treat the LV dysfunction with, if patient is moribund and in hypotension, you give them inotropes, IABP. The key is keep the patient alive, because for most part it is reversible. Overall good prognosis, somebody said. Only thing is you have to keep the patient alive during the acute phase. They should not die of arrhythmias. Many a time what happens is you do angiogram, you find it normal, you say, oh, nothing doing, this is all okay. Shift him to the patient to ward, and patient has an arrhythmic event in ward, and where he or she is not shocked, and patient dies. This is unfortunate because this is a practically reversible cause. Up to 8% mortality has been reported, and the recovery can take up to 1 to 4 weeks. Importantly, some patients do have susceptibility to it, maybe genetic, because 10% patients can have recurrence. So take-home messages are very clear. So here we come over here again to another diagnosis. So remember all these points, they all will be asked. So tell me all the findings, all, many of them are there. Dr. Safal sir. So I think once let these people type. RAO 30 degree. Okay, RAO view. Very, very nice. RAO view, because your catheter in the right side, we cannot see the spine. Okay, so there is almost complete obliteration of the mid cavity, and to some extent, why it is? Do you think it will be that severe, or there is something else at play? Severe MR. Okay, very good. Why do you call it severe? Why do you call MR severe? And do you think, I mean, if I remove this catheter, do you think this is complete obliteration of the mid cavity? So what phenomena is happening? Grade 3 MR. Okay, it's a severe MR. We'll see, talk about grading a little while later. See, what is the catheter doing? Is it normal sinus rhythm or something else is happening? That's what I want to ask. And that is sort of, exacerbating the whole issue. So our injection is causing a lot of VPCs. Very good. Somebody has answered. So they are catheter-induced ectopics. And so they are, and what happens if the contractility is increased? In the just beat after ectopics, they will increase contractile, and which will increase the gradient. So MR is exaggerated, very, very good. And similarly, the left ventricular outflow tract, or for that matter, this mid cavity gradient gets exaggerated. So I believe that there is some sort of, increased, what we find is they are exaggerated findings. Okay, very good. Broken row phenomenon. Very good. So many things can be described over here, can be seen over here. So this is all about it. So there is this thing. What about this one? Post MR won't increase. Somebody is seeing on chat box. But post PVC MR. See, what happens is, if you induce VPC, what will happen is that ventricle may contract when the valve is closed. So those kind of things can occur. Okay, well, so we move over to this one. Tell me about this one. Apical thrombus. Why is apical? Very good. Why is it formed? What is the likely pathology?
When you are saying apical thrombus and not a tumor, you will have to comment on something else. Apical thrombus is what? You will have to tell us. Yes, you will have to tell us about the LV at that place. Only then we will entertain a diagnosis of thrombus.
Hypokinetic. Do you think this is See, I showed you one slide. It was a simple slide, but will you call it a hypokinetic? What is hypokinetic apex? Hypo means Hypokinetic means that it is moving but moving less. It may be very, very less. But do you think this is hypokinetic?
Especially when you're seeing a thrombus.
Yes, especially when you are seeing a thrombus. Severe hypokinesia, you may say, I mean, on echo, you find some degree of thickening and you may say. It is akinetic to practically, you can call it akinetic, agreed. Maybe a little bit disconnected, but it is akinetic, agreed, because actually dye is not going over there at all. It's a huge thrombus. So what is the possible etiology actually? There are two questions. What is possible etiology? Number one, though the angiogram is a little, it is not that long. But second thing, I want to know whether this thrombus is new or old. Whether this thrombus is new or old. It has been recently formed or it has been there, because you will find thrombi in, in old MI patient, they are, part of their lives. It's an old thrombus. Okay. Why do you call it an organized thrombus? Why? How can, thrombus is adhered to the wall. Okay. Okay. But how does it, okay. Layered thrombus, maybe ischemic or non-ischemic, white shadow. Okay. See, a old thrombus will be a calcified thrombus. Likely calcified. Not in all cases, but in general, thrombi will ultimately calcify if they have been present for a long, long time.
One boy has written, I think, organized with mild calcium.
Okay. So, actually, for calcium, we should have, see, and let me stop it over here. It's a small one, let me show here. So, I cannot see any calcium actually. There may be a little bit of it, but Dr. Safal, this is not a long view actually. Yeah. So, and the image is not of very great quality. So, this is a compressed image, and but at least very, very marked calcium is not there. And actually diagnosis is different, so I am a little biased because I know the diagnosis. So in general, you have to see whether it is calcified or not. So this is not involving any territory. This was a case of Takotsubo cardiomyopathy with obviously somebody has done LV angio. So surely that fellow must have done the corneas, which are there. I've not shown them because otherwise it will always be getting too late. So this is a Takotsubo because it is not involving in any category. However, somebody has rightly said anti-wall and myocardial infarction is the way to go. Tell me all the findings. All whatever you see. No perfusion in thrombus old. No, thrombus will be layered. Even in acute ones, you will have this kind of picture only. So this is a typically fresh thrombus, the previous one which we saw. Likely, of course, you have to lie on history and all things also. So what all you see over here? RO view, okay, view, at least people are clear about the views. RO view. Catheter in the MPA, very, very good. I am impressed. One catheter is there in the MPA. So, severe MR. So, somebody has put a catheter in the main pulmonary artery. So, they want to measure this thing. So, patient must be in relatively bad shape for some reason or the other. But LV looks relatively okay, except perhaps some doubtful basal hypokinesia. And there is severe MR. And in mitral, in the left atrium, can you see the left atrial appendage? Where is the left atrial appendage? So it is a generally severe MR. You can see in the previous ones, you are not able to see it so well. So this is the left atrial appendage, which you can see. This is the just over here. So this is a severe mitral regurgitation and PA catheter. So this is how you define the MR. In the mild one, regurgitation clears with each beat. never opacifies the left atrium. In fact, you will see a small jet. I had one angiogram, I don't know, I missed it or where it is. You will see a jet over here of the when the left ventricular contracts going into the left atrium. Moderate regurgitation does not clear with one beat and generally does opacify the left atrium faintly. And in moderately severe, completely opacified, equal opacification. In the severe MR, grade 4, the LA opacifies much more and becomes progressively more dense with each beat. So this is how you grade it. You have to know this grading because this is asked in the exams. So tell me what's the problem over here? Okay, yes, dilated LA, very good. So this was a likely patient with heart failure with preserved ejection fraction, and he had a dilated LA. Very good, very, very good. I like it. The previous one, somebody talked about it. Okay, very, very good, very good. I like it again. Somebody has said, how many stents are there actually? So very good. So attention to detail, that's the key. In interventional cardiology, attention to detail. You have to know each and every aspect of it. So I can say one thing that there is a one long stent and then there is some small stent. So it must have been a very diffuse kind of disease that practically till crux or so this is. So basal hypokinesia, and it is extending up to the apex also. See, LAD, I expect it may have disease, but it is not infarcted at all. It is contracting very well. In fact, it is to some extent hypercontractile. Hyperkinesis is there, which is compensatory. Very good. So this all area till the apex, this area is our preserved. So this is basically because of the this is not from this patient. This angiogram is from some other subject, not from this one. So there may be a superdominant RC. Typically it will involve the LCX, but PDA can extend, it may be wrap around. So this was a superdominant and this thing. So tell me, what is the problem over here? Actually, I've removed the other views. I should have taken them. So what is the problem over here? Pericardial effusion. Okay. So pericardial effusion is there. Actually, this is post PDC actually. Patient was shifted out and brought back to cath lab because this was rejected. So what is being done? What is being done and why it is being done, and tell me the whole procedure quickly in one line. Tamponade. See, tamponade is a diagnosis. It can occur with small effusion also, especially in acute cases. But it's a hemodynamic diagnosis. You need some sort of pressure data. Of course, if it is... Tell me all the findings quickly. Pericardiosynthesis is being done. So the operator has taken through a needle and wants to check whether I am the right track or not. And he has injected a little bit of dye. But in any case, dye was which has opacified the whole thing. And what all is can you see? Tell me quickly. Why the procedure was done? Which artery was tackled? I want to see. I want to know what procedure resulted in this catastrophe that we have to do this kind of thing. Pericardiosynthesis, LAD. Very good. Why? Quickly. I will not budge unless you answer. There is no point. I can show you. In this, I have 500 spotters. In this, they are in continuation mode. LAD perforation. Why? Can you see anything? Stent is very good. Very good. So you have to be, attentive. There is a beautifully, you can see a stent. It is likely a LAD perforation. And importantly, yes, very good. Now you have come out very good. I'm very happy. And this you see this basal wall is still quite contractile. Here, the apex is not moving at all. And you can see over here, what is this structure? Some moving structure is there. What is this? What is this? It is difficult to say whether it is because of excessive port dilatation or whatever. It is one of the causes. Okay, it is kinetic. What do you see moving structure over here? This kinetic apex. Okay, very good, excellent. What is this? There is some structure over here attached. This is a clot, my dear friend. This is a clot which is so a clot has formed over here, which is moving like a vegetation, which you see in infected endocarditis. So you have to not only see, anybody can say, I'm not a to show you this one. This was too simple. So you have to see each and everything. And LV is a little bit dilated also. And I think I showed you the other one, this one. Okay. This one, this injecting, and same thing. And okay, they actually I'm not removed. So what is there? This was somebody was putting in a central venous catheter and went too deep actually. Pneumopericardium, very good. So you see air in the pericardium. It should not happen. You have to be careful. Okay. So tell Dr. Safal, you want to comment on this one? I mean, I don't know whether it is really. What is this? So tell me everything. PTMC, balloon, type of balloon, where is it? Is it in the RV, LV, view? Quickly.
The view start. Somebody has said.
Dr. Safal said you initially. You will always jump to this thing. See, examiner is showing you this thing. I mean, you have to tell a little bit of this thing, because tomorrow you will go to do a procedure of whatever you are describing, and you will not know which view to take the balloon. So all these things are important. I have not shown you this picture just to show you this balloon. So everything, it's a complete kind of situation. You have to know, you have to do BMB, in which view you will dilate this balloon.
So somebody says RAO now for PTMC.
Okay, and very good. So this is the procedure. And tell me the catheters. Tell me the catheters.
So INAO practically was the only one that was used till some time ago. But now on fluoroscopy, you really cannot make out the difference between INAO and some of these made in India catheters, including Acura, etc. So suffice to say, a BMV balloon. Yeah, now come to this part. Somebody has answered going from RA to LA through septal puncture. So if I go by
ultimately, yes, sorry, please.
So according to you, we are doing an atrial septostomy over here, RA to LA, and then dilating the balloon.
Please answer. Even if you answer incorrectly, it is okay. Somebody is saying yes, sir. So according to them, septal dilatation is being done. It is a transseptal puncture which is being performed. Transseptal puncture. So I'm happy that I put this spot, because I thought it will be a little bit loosened. No. So where is the balloon? So Dr. Safal sir is asking where is RA to LA to LV over the mitral valve. Okay, good.
Yeah, that is what the classical picture is. You can see we are initially in the LV. We are withdrawing it. That is classically, if you see from the beginning, that is exactly what is done. This is the RAO view. You see your balloon now distally, you've inflated it, you pulled it back, and then it has stopped at the mitral valve.
And where is the pigtail? And why pigtail has been kept? Somebody has kept it. We generally don't keep it, but somebody has kept it. It is okay, perfectly okay. Maybe it was a high risk kind of BMB, but I do not see any calcium actually over here. I do not see a calcified valve. Otherwise, I would have seen some sort of calcium over here if it were a calcified valve, but I cannot see it at least over here. So sometimes you may not see it, but surely it was not too much. So there is a pigtail, okay, in the LV for measuring gradient or LVDP. Very good. Rightly answered with this fellow. Very good, very good. So as Sir said that you have to describe each and every finding. You just do not say that I see a balloon which is being dilated. So you have to describe the whole thing. You have to see, because many a time examiner will be interested and will be impressed, or otherwise also, if you are but all most people will not comment. So you have to know each and everything. So this is how it is. You have a AML over here, PML over here, and you do it like and in between this is the basically valve in diastole and in systole. By this time you must be aware of this thing. So identify all the structures. Quickly.
Beautiful angiogram.
And pathology also. Everything is so beautifully seen. Everything is so beautifully seen. I mean, these days you will really see this kind of angiogram. People will not do it actually. Etiology I also want to know. Severe pulmonary vein. Okay, good. So you can see even pulmonary vein ossification. So this makes it a grade 4 MR, clear-cut grade 4 MR. See, even pulmonary veins are getting filled over here. Very good. I am impressed. Severe MR, huge LA and left atrial appendage, beautifully seen. We saw it earlier on, but here it is like a some very nicely seen. And I'm particularly impressed by somebody saying these pulmonary veins can be seen. I mean, it's good. At least. Okay. RO with severe MR dilatation, LAO, mostly rheumatic. Why do you call it rheumatic? LA clot. Can you see a clot over here? Clot will be actually filling defect. Maybe somebody is confusing it with this thing. I cannot see a clot because then you will have a filling defect. But nevertheless, still, truncus arteriosus. Truncus arteriosus.
Where did that come from?
This is not truncus. Will not go into truncus arteriosus. My belief is that congenital heart disease is not in their course. So that is why I have to diffuse many speakers that no, we don't want. Only ASD, VSD, PD, RSOV, I mean those kind of things are in their course, it appears. Okay, severe MR, RHD. Why RHD? You have a beautiful heart. I mean, very good contractility. Why RHD? Why quickly? Guesswork?
Just for the candidate who said truncus, if you would come through the truncus, you would have to be filling both the RV and the LV, or that single ventricle which would fill everything. So means that's absolutely a wild answer.
Yes, that's a. So where is the right pulmonary artery is not getting filled. So truncus basically means that you have a valve which is a common kind of valve for both the ventricles. So pathology, nobody is able to dilated appendage. Dilated appendage. Okay. See, LA is dilated appendage is also dilated. Okay. See, focus over here on these leaflets. Focus here. I showed you everything is. I have taken great pains to collect these and arrange them in a proper manner. So I want a full impact. you will rarely see these kind of angiograms these days. See the leaflets. Normally, normal leaflets you are not able to see. They are so thin. See the leaflets carefully. I think I'll have to stop it. Leaflets are thickened. I mean, they are of varying thickness at various points of time. See, this is the leaflet.
Wonderful frame. Yes.
See these leaflets. And maybe you can see the jet coming out also. You have a perhaps non-coapting thickened leaflets. Now you will see it over here again once I'll run them. See it. You will rarely see this because no one does it actually. See. Normally you will not be able to see leaflets. You have seen so many of them. Thickened leaflets. See it again. Remember it. Okay. So this is severe MR and typically, and rightly said, dilated this thing and all that. Okay. AML prolapse and those kind of. So calcified, yes. They are calcified, thickened. I cannot see calcification that much because our angiogram is a little short, but yes, they are thickened, and so remember it. So this is a 19-year-old male with chest pain.
I think we keep this as the last spot, sir. We'll be running short of time. I think.
Yeah, this will be a last one. We'll cover it later on. So this will be last one. So see it carefully. In myxomatous, you have elongated, not that much thickened. Somebody is commenting on the previous one. So you will have elongated this thing. So this was purely, the previous one was purely 100% rheumatic. And they'll be thin. And they'll be flail. Flail means this leaflet tip is going. Dr. Safal, I think, showed you one of those cases. I am not sure.
Look at all the views. All three views are here for you.
See over here. This is the posterior mitral leaflet. We saw it. And there is something coming out over here. There is some sort of leak over here. In this view, it is a little bit less clearer. In this view, this is crystal clear. This is RO view. This is LO view. And this is lateral view. Lateral view is nothing but dead. LO view means 90 degree. You have a sternum over here, and you have a catheter as well as your spine over here. And you see over here something is filling over here. So this was a case.
So think about it. We are in the LV. Something is filling, which is actually posterior to the LV. Look at the third image. Comment on the LV. It is a relatively healthy LV.
And a young fellow. And to tell you, corneas were normal. A little bit of plaque in one of them.
Somebody is writing VSD. See the third view. The RV was.
Yes, somebody has said it already. So this is aneurysm actually.
Yeah.
First you have to tell. If you tell aneurysm, I think you will get 99% marks. For 1%, you can always debate because somebody has said some mitral aneurysm. So 1 or 2 lines, this was so this is aneurysm. This is a rugged cavity, this kind of thing. So they can rupture and create havoc, and so they need to be treated. But surgery is not without harm. Lots of mortality with surgery. They are rare. Last slide. Occur typically underneath the posterior leaflet of the mitral valve and below the intermediate portion of the left aortic sinus. So basic pathology is a congenital defect, some sort of weakness, and ultimately it has given way later on. Patients may be asymptomatic, incidentally detected, or present with mitral insufficiency with or without LV dysfunction. They may even present with ischemia because aneurysm, impinges on the coronaries. They can present with arrhythmias, they can present with thromboembolism. As you see, this aneurysm is a large one. So no wonder thrombus can form over here. Okay, so with that we will continue later on in our next future. Next time we have a class on endovascular aneurysms or repair and all those kind of things. Okay.
Very fine, very fine collection, sir, of
On-
a thing which is not very commonly done. So then picking up that collection must have been very hard.
No, it is well. I might have taken some from you, stolen from you also. So do forgive me. Okay. With that, perhaps we can, with Dr. Safal, you can call it a day. You have to
Yes,
only
sir.
say the final words.
Very productive session. Thank you, sir.
Thank you. So, Navneet Singh sir is here because my screen is set in such a way I cannot see everybody actually. Okay, with that we end it with the permission of Mr. Navneet Singh ji. Okay, Dr. Safal, thanks a lot. Grateful. Thank you, sir.